Clinical assessments and interventions on bipolar disorder. The intro. Have you ever had energy even though you weren't getting sleep? Have you had unexpected shifts in your mood? Do you talk continuously? Are you easily distracted? Do you participate in reckless behaviors without caring about the consequences? If you answered yes to those questions, you may have a form of bipolar disorder. Let's take a little look. The National Institute of Mental Health described bipolar disorder as a mental illness that causes clear shifts in a person's energy, mood, activity levels, and concentration. The two types of bipolar disorder are bipolar 1 and bipolar 2. It is a disorder that contains either a mania or a hypomania stage or both. Commonly seen in bipolar 1 diagnoses is mania. It is when an individual's mood has shifts of energy and irritability that begins to cause disruptions in their life that usually lasts at least a week, and it occurs for most of the day, and sometimes it can cause a hospitalization. Hypomania is when an individual's mood has shift of energy and or irritability that does not cause disruptions in the day-to-day life functions, but this typically needs to occur for at least 4 consecutive days, which is commonly seen in bipolar 2 but can also be seen in bipolar 1. So which bipolar order are we going to be looking at into more depth today? That's going to be bipolar 1. How is bipolar 1 diagnosed? Per the DSM-5-TR, to meet the criteria for bipolar 1 diagnosis, an individual must meet the following. They must have at least one manic episode. This is non-negotiable for this diagnosis. For bipolar 1 diagnosis, someone has to have a manic episode, with a minimum of 3 symptoms of mania that last for a week or more, or 4 if the mood is only irritable. Manic symptoms include inflated self-esteem, an example of that's feeling untouchable, decreased need for sleep, where someone's ready just to take on the world with little or no sleep, usually less than 3 hours of sleep at night, more talkative than usual, so someone that is just always continuously talking, even if they're not talking about what's relevant to the conversation. Flight of ideals and or racing thoughts. So someone that never slows down, they're constantly voicing different thoughts that may or may not pertain to what is being talked about. Distractibility, unable to stick to someone's task, which could end up leading someone to not complete their original task at hand or any task. Increased goal-directed activity, taking on too many projects at once is usually a good example of this. So for example, if it was a student and they decided to do every sport at school plus do every club at school. Excessive involvement in activities, this also goes hand in hand, but usually these activities lead to negative consequences. So this would be taking reckless risk, such as overspending, not just a little bit overspending, but drastically overspending, and it usually causes devastation to their families. The symptoms must be severe enough to cause a problem within everyday functioning, and that could lead to the hospitalization. Symptoms cannot be linked to substance abuse, medication use, or any other type of medical condition. The manic stage can be followed by a hypomanic stage as well as a depressive mood. So the hypomanic symptoms are very similar to the manic symptoms, and they include a minimum of 3 symptoms of mania that lasts a week or more, or 4 if the mood is only irritable. Inflected self-esteem, decreased need for sleep, more talkative than usual, flight of ideals, distractibility, increased goal-directed activity, excessive involvement in activities that have a high potential for painful consequences. Excuse me. The episode is associated with change in functioning that is uncharacteristic of the individual when not symptomatic. The disturbance in mood and the change in functioning are observable by others. The episode is not severe enough to cause a marked impairment in the everyday function, and it does not necessitate hospitalization stays. In the major depressive episode, which is the last criteria that could be present in bipolar 1 per the DSM-5-TR, an individual must have 5 or more of the following symptoms that must last at least for a period of 2 weeks. You're going to notice that a lot of these are going to be similar to what we're about to talk about. The major depressive episode symptoms are, it must include a depressed mood or loss of interest. Depressed moods must be for most of the day, nearly every single day. Diminished interest of pleasure in all or almost all activities for most of the day. Insomnia or hypersomnia nearly every day. Agitation nearly every day. Fatigue or loss of energy nearly every day. A feeling of worthlessness or excessive inappropriate guilt, the diminished ability to think or concentrate, or indecisiveness that usually lasts every single day, and then recurrent fear of death, recurrent suicidal ideations is seen here. Once again, this also cannot be attributed to substance abuse. It must cause an impairment in everyday functioning. So could bipolar 1 be mistaken for another disorder? Absolutely. There are several disorders that resemble bipolar 1, making it easy for a misdiagnosis. A misdiagnosis is when someone is given an incorrect diagnosis for a condition that they do not have. According to the National Library of Medicine, there was a case study of 177 individuals, and of those 177 individuals, 136 bipolar cases were misdiagnosed, equaling at a 76.8% misdiagnosis rate. That is huge. With 31% of the individuals with bipolar disorder being misdiagnosed. The main misdiagnosis was noted in the study for major depressive disorder. Other leading misdiagnoses was schizophrenia, psychoaffective disorder, and substance use with psychosymptoms. It is because of these misdiagnoses that it is important for a clinician to look at all possible diagnoses, known as a differential diagnosis. What is a differential diagnosis? It is a diagnosis that allows the clinicians to use a process of elimination by looking at individual symptoms and evaluating them toward other disorders that may have similar or the same symptoms. And it's through this process of elimination that they are able to rule out each disorder. So let's look a little bit into major depressive disorder. It is a really good differential diagnosis for bipolar 1 due to the fact that they have a lot of the same similar symptoms. The major difference in major depressive disorder and bipolar 1 is major depressive disorder does not have that manic stage. And remember, the manic stage has to be present for someone to be diagnosed with bipolar 1. Per the DSM-5-TR, an individual must have 5 of the following symptoms that must last for at least a period of 2 weeks, which, as you notice, that is the same as it was for bipolar 1. Depressed mood most of the day, nearly every day. Markedly diminished interest or pleasure in all or almost all activities. Significant weight loss when not dieting or weight gain. That is actually not listed as part of the bipolar 1 criteria. Insomnia or hypersomnia nearly every day. Severe agitation, fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive inappropriate guilt, diminished ability to think or concentrate, and once again, recurrent thoughts of death, recurrent suicidal ideations without a specific plan. It also cannot be attributed to substance abuse, and it must cause impairment in everyday functioning. Another disorder that is very common with the same symptoms as bipolar 1 disorder is schizoaffective disorder. It must have one or both a depressed or manic episode, must have at least 2 weeks of seeing or hearing things that was not present without having a manic or depressed mood episode. That is your major difference between schizoaffective and bipolar 1 disorder. Major mood symptoms are present for most of the diagnosis. It cannot be because of a substance abuse disorder. And schizoaffective does have subdiagnoses that can have bipolar and depressive types for their criteria. How must we distinguish between the diagnoses? A clinician must distinguish between the diagnoses by looking at each individual symptom to determine where they would most resemble the diagnosis that was determined to be looked at. The differences between bipolar 1 and MDD, which is your major depressive disorder, is that, once again, the major depressive disorder does not have a manic episode, which must be present for someone with bipolar 1. The major difference between bipolar 1 and schizoaffective is hallucinations. In bipolar 1, they only occur during the mood episodes, whereas in schizoaffective, the hallucinations must occur for at least a 2-week time span. Is bipolar 1 a common diagnosis? Yeah. Per the World Health Organization, 1 in 200 people are affected by bipolar disorder, which is roughly 37 million people. The third most common mental health diagnosis that causes inpatient hospital stays is bipolar 1 diagnosis. It's most common in adults between the ages of 18 and 25. However, it can be diagnosed in juveniles between the age of 13 through 18. There wasn't any correlation between men and women on who was diagnosed more efficiently with the bipolar 1. However, in one of the studies I looked at, men did tend to have a slightly higher rate at 2.9%, while women was at 2.8%. So it's just right there hand in hand. However, women are more favorable to be the ones to look for treatment and get the treatment. Now, these statistics are completely opposite for teenagers, as in teenagers, females had a higher diagnosis than male teenagers. The highest rate for bipolar diagnosis was actually in Native Americans at 1.5%, with Caucasians being very close in that race. Asians actually had the lowest diagnosis, whereas the state of Illinois had the highest rate of inpatient stays for bipolar disorder across the United States at about 150.6 days out of 100,000 people. I believe that this is because they have very limited mental health treatments for bipolar disorder. So how can bipolar 1 disorder affect an individual? Someone living with bipolar tends to have shifts in mood, making it difficult for them to maintain positive relationship with others. It could cause withdrawal symptoms. I wanted to give just a real quick story. I have a friend and a colleague who has actually never been diagnosed with bipolar, but she does take several different medications for mental health issues. But she will go through several months of manic episodes where she cuts off all communication with anyone around her. And it doesn't matter how long, as long as she's in one of her episodes, she will not talk to any person around her. And then once she's out of it, she'll just call somebody and try to reconnect as if nothing ever happened. Which has caused her to lose a lot of friendships as well as other types of jobs. It also is affecting her relationship right now with her spouse. Bipolar disorder causes someone's family to be alert and anxious because they're always waiting for the next episode, which can cause strain within that relationship. Bipolar 1 can also cause an individual to have difficult time maintaining employment due to them going into their manic stages or hypomanic stages. It can cause difficulty in marriages or relationships, leading to divorces or breakups, especially when there's risky behaviors that are being demonstrated. Those risky behaviors could be where they're overspending, causing financial issues, where they're out there having multiple sexual interactions, just anything that could be reckless or detrimental. So why does bipolar 1 even occur? Do we know? Yeah, no, not really. There's not a known reason on why bipolar occurs. It's believed that genes and stressful events such as childhood trauma can lead to a diagnosis of bipolar. There is an epigenetic theory. It is where a change in the genetic function is believed to be due to environmental influences because the DNA is unchanged. It's believed that someone can turn their genes on and off, kind of like a light switch, starting with a pregnant mother, which can allow someone to inherit the genes to be bipolar. So that mom's emotions and stress and anxiety can change that genetic environmental genes of that baby. It's believed that when this is the case, you can look at someone's DNA markers, such as the DNA methylactation, to determine what treatment would work best for that individual. There's also a neurotransmitter theory. It is believed that neurotransmitters are regulated normally in the brain for bipolar disorders, causing impaired functioning in the limbic system that causes symptoms of bipolar disorder. These transmitters are noradrenaline, serotonin, and dopamine. When serotonin is low, it can cause symptoms of depression. When dopamine is elevated, it can cause high energy, and when it's low, it can cause extreme fatigue. When you're looking at the noradrenaline, it is low. In individuals, they typically experience those depressive episodes we've been talking about. The best treatment for this theory is placing a patient on lithium. So what interventions, psychosocial and psychopharmacological, could we look at for bipolar disorders? One of the psychosocial interventions that I found was interpersonal and social rhyme therapy. It is developed to help manage patient stressful life events, improve the disruptions of social rhymes, and increase adherence to medications. So it focuses on routines and relationships by creating a schedule for the individual while addressing stress and coping skills. So it puts someone on a strict schedule where they have to follow a strict routine every day. They wake up at a certain time, they eat at a certain time, they go to bed at a certain time, which tends to help their moods. It also shows that improvement in anxious, depressive, and manic episodes. They also work on family relationships and learning how to deal with those stressful situations that might occur within the family. That way they're able to work through that if it occurs again. As far as the psychopharmacological intervention, you're looking at more of like mood stabilizers, such as lithium is a huge one. Lithium has a 90% reduced suicide rate for those that will take it with bipolar 1 disorder. However, even though that's huge for lowering suicide rate, it has really bad adverse effects on your organs, such as your kidneys and thyroid, which in return requires for blood work to be done every so often. Due to the blood work having to be done so frequently, a lot of people will come off their medications, or they won't go in and get their lab work done, so then they're looking at possibly lithium toxicity. Individuals could have poor responses to lithium as well, causing increase in their bipolar symptoms. Lithium is a great medication and it's usually a long-term medication. However, after so long, usually an individual needs to be placed on another medication as well to help reduce their symptoms. So we've discussed a lot already. Let's talk about some community resources that we have for individuals with bipolar 1 disorders. So in the state of Tennessee, we offer a Depression and Bipolar Support Alliance program. This program offers peer supports to individuals and families for those suffering with bipolar. This group is beneficial because it allows those suffering with the illness and their families understand that they are not alone. It gives a sense of support while also learning more about additional services in one's community to assist with the bipolar disorder. If someone wanted to access this resource, you can do so by emailing or by visiting their website, which I've attached. We have also a specific treatment program for bipolar disorders, such as the Bipolar Treatment Center through the East Tennessee Behavioral Health. This can be an inpatient treatment center, and it also goes out to outpatient. They focus on providing individual therapy, medication management, 24/7 inpatient care. Once you get out of the inpatient care, if you wanted to follow the aftercare services, you could do that. Group therapy, CBT therapy, and DBT therapy they focus on as well. You can set up a referral with them just by calling their admissions team, and the admissions team puts in the referral for you. So in conclusion, bipolar 1 disorder left untreated can drastically affect someone's life. Not only does it affect their mental health, but eventually the negative behaviors trickles down into all aspects of an individual's life that can cause loss of employment, relationship problems, physical health, and financial aspects of life. When treated with the correct medications and therapies, the success rate is high, with less suicides and hospitalizations needed. If you're experiencing symptoms of bipolar disorder, please reach out to someone and get the help that you need. Thank you.